tissue and neuromuscular therapy. The torso.
Deep tissue massage is specific, efficient, penetrating, and effective. It uses elbows, fists, and knuckles as tools, addresses the source of pain, yet does not have to be painful.
Hi, my name is Sean Reel. Welcome to my video on deep tissue massage and neuromuscular therapy, the torso. In this video, we'll cover massage techniques for the hip, the back, the neck, and the shoulder girdle muscles. We'll cover each section from a functional perspective. This means that I group the muscles by what they do, not where they are. So for example, the hip section is organized into hip adductors, abductors, flexors, and the extensors. In my experience, this is the most effective way to teach massage because it allows the thinking of the therapist to be in alignment with how the body actually works. It also makes it very easy to evaluate each muscle group for pain, and in this video I'll show ways to evaluate the various muscle groups. For ease of understanding in the beginning of each section, I have made the muscles out of clay and applied them to a small skeleton. In this way you can get a three-dimensional view of the muscles and see how they relate to each other. What is neuromuscular therapy? Neuromuscular therapy is a specific form of massage that focuses on releasing trigger points. Trigger points are simply very irritated tissue that has begun to overwhelm the spinal cord with pain signals, causing the person to feel like the pain is coming from someplace else. This means that the pain that they feel across their sacrum, for example, may actually be coming from their quadratus lumborum muscle, or the headache that the client feels may be coming from their neck, or the top of the trapezius on their shoulder. Knowing about trigger points is essential in discovering the true cause of pain. In this video, I have used a computer to generate trigger points and their referral patterns. Red X's indicate likely areas of trigger points, and large red areas are where those X's have a tendency to refer pain. Not everyone will have the exact referral patterns shown in this video because everyone's nerve pathways are slightly different. The referral patterns shown are just the most common and are accurate about 75% of the time. The next question is, how do you perform trigger point massage? Trigger point therapy is the same as normal massage with a few added considerations and a different intention. The first part in performing trigger point therapy is to search for sensitive tissue. You should already know how to do this well with your massage techniques that you know. When you find a sore spot, stay there and apply static pressure. You can use your thumbs, your knuckles, your fingers, or your elbow, and we'll talk later about how to use each of these tools appropriately. At this point, you want to question your client and ask them, is this spot referring any place, or do you feel this anyplace else? The best thing that can happen is that your client says, oh yeah, that's exactly where I feel the pain. If they say this, you know that this is the source of the pain. And that's great because once you release this muscle, their complaint should go away. Oftentimes you will find tender spots that don't refer pain. These are great to work on but are not trigger points. They only become trigger points when the tissues become so inflamed that they start to refer pain. There are some other considerations when doing trigger point work, like how long should you apply pressure for? There are many different philosophies on this point, ranging from 8 seconds to a whole minute. I believe that every client is different and that no therapist should rigidly stick to some rule, but that body work should always be semi-intuitive. There are, however, a few guidelines that can help you choose how long to stay on one spot. With lighter pressures, it's okay to apply pressure for a longer time, maybe a minute, because part of the time you're waiting to sink into the tissues to get to that deep muscle that you're focusing on. With deeper pressures, a shorter time period is appropriate because your concern here is overstimulating or damaging the tissues. What you are really looking for is enough pressure and time to affect a change in the tissues. But this is all balanced by not wanting to bruise or damage the tissue or create such a reaction that the body tries to resist the work, tightening up even more. So how do you know if the pressure is appropriate? With appropriate pressure, the initial soreness that is encountered starts to dissipate after 10 to 30 seconds. I've done this in classes where each student finds a sore spot on themselves and applies pressure while watching the clock. They measure how many seconds it takes for the pain to diminish. The pain usually diminishes after 10 to 30 seconds, sometimes a little longer. This is our nervous system responding to the increased pain signals. To do this with your client, hold an area and ask them to tell you when the pain eases up. If the pain does not ease up, then there are two things that may be happening. One, you may be pushing too hard, or two, you may be pushing on a nerve. If you're pushing too hard, then you're not giving the body a chance to create a healing response to your work. So lighten up. If you're pushing on a nerve, you will know because the pain usually will stay the same or increase. Nerve pressure also will commonly cause tingling, burning, or numbness, so watch for these signs. But be alert, because trigger points can also cause burning and tingling, but the difference is that trigger points ease up after time, where nerve pain doesn't. Okay, some more about pressure. The pressure should always be within your client's pain tolerance. Remember, deep tissue massage does not have to be painful to be effective. The best thing to tell your clients is that if they start to tighten up in response to the pressure, you're going too deep. The client should be able to stay relaxed and at ease while receiving the work. You can also use a pain scale. 0 being feather touch and 10 being excruciatingly painful. I never work above an 8. That's the line where it's penetrating but tolerable. There are a few other tricks in assessing the appropriate pressure for your clients. There are 4 questions that you can ask in your client intake that will give you clues about how deep to work. The first question is, have you ever had a massage before? If they've never received massage or never received deep massage, be gentler. If they have received massage, ask them question number 2. Were you ever sore from the work that you received? If they did experience soreness, that is a caution sign. The third question is, do you bruise easily? Hopefully this question won't scare them off. But if the answer is yes, that they do bruise easily, then use a lighter pressure. I've noticed that people with very fair skin tend to be more sensitive to bruising than those with dark skin. The fourth question to ask is, do you exercise regularly? People who exercise tend to have healthier tissue and can take more pressure. If the person doesn't exercise regularly and also bruises easily and was sore from previous massages, be gentle with your work. My rule is that deep massage should be deep enough to elicit a healing response in the tissues without causing bruising or soreness that lasts for more than 1 day. If the client is still sore for 2 days after the massage, then you went too deep. Okay, what'd I just say? Trigger points are areas that refer pain. Trigger point tenderness should dissipate after 30 seconds. Ask your clients, does this refer any place? If the soreness increases, you're pushing on a nerve. If you're working too deeply, your client is sore for more than 1 day. Use a pain scale for depth. Assess appropriate depth by asking your clients, 1, have you had deep massage before? 2, were you ever sore from that work that you received? 3, do you bruise easily? And 4, do you exercise regularly? Working with injuries. The desire to work with injured people is one of the main reasons that massage therapists become trained in deep tissue and neuromuscular therapy. I will be showing you how to help many conditions of the torso. Sometimes, however, massage is not the appropriate treatment, and as a massage therapist, you should already know many contraindications to massage. If you need more information on contraindications, get a book on the subject. There are, however, 2 issues I would like to address. The first is the initial inflammatory stage. This is the first stage after someone becomes injured and lasts from 1 to 3 days. This stage is characterized by the tissues being red, hot, swollen, and painful. During this stage, massage is not appropriate. What is appropriate is RICE, R-I-C-E, rest, ice, compression, and elevation. After the swelling has gone down, oftentimes the muscle will begin to tighten up, and it is during this time when massage becomes appropriate. The second caution is any acute, undiagnosed injury or pain. The key word here is acute. Don't put yourself at risk. Let the MDs take the responsibility and the liability for certifying that someone is safe to work on. There are 4 modalities that we will use in this video. Stripping strokes, static pressure with joint movement, and stretches. First, we'll discuss static pressure and correct application of pressure. Then we'll look at stripping strokes and correct body mechanics. And finally, the basics of assessment. But before we start, let's get the table set to the correct height. For deep tissue massage, lower the table so that your proximal interphalangeal joints swing freely. Make the table even lower for larger clients. Static pressure. Static pressure is also called ischemic compression or ischemic compression, and is useful in releasing trigger points. It is one of the most potent ways to release the tissues, and yet is also one of the safest techniques to use when a client has a great deal of soreness or inflammation. 3 secrets to correct application of static pressure. Secret number 1. Apply pressure at 90 degrees to the body. In order for our body work to be potent, we need to gain access to the deeper muscle layers. We can do this by applying pressure directly onto whatever structure we are working on. Our body is made up of cylinder shapes, which means that to apply pressure directly into the tissue, we should be at a 90-degree angle to the body. Secret number 2, line up your joints. The position of our bones determines where the pressure is going. When using our thumbs, the phalange bone should always point towards the area that we're working on, with all our other joints above aligned. By aligning the joints, we allow the bones to do the work of transmitting force, rather than the ligaments or the muscles. This keeps the practitioner's body pain-free. Sometimes it's hard to keep the thumb going straight, so brace the thumb on the index finger to keep it straight while applying deep pressure. Secret number 3, stand in the right position. We can only line up our joints if our body is in the correct position in relationship to our client. Wherever we choose to work, that part of the body should be facing us. For example, if we wish to work on the quadratus lumborum muscle with the client prone, we should stand at their side. If we want to work on the upper back with the client prone, we should stand at their head. If we stand in the correct position with our joints aligned, we will avoid injury. Stripping strokes. Stripping strokes are the application of very slow and deep gliding pressure along the length of the muscle fibers. Stripping strokes release and elongate tightened muscle and fascia, flush the muscle with fresh blood, and erase trigger points. Stripping strokes are performed using the elbow, the forearm, the knuckles, or the thumb. The elbow and the forearm are used for larger muscles, and the knuckles and the thumbs are used for detail work and smaller muscles. 9 points of proper forearm mechanics. The forearm is one of the most useful tools in performing long, sweeping, general strokes. These have the benefit of being soothing and relaxing, as well as being deeply penetrating and effective for clearing the muscle tissue of waste and tension. There are 9 points to be aware of when performing the forearm stroke. Number 1, don't let the shoulder lead the elbow joint or fall too far behind. The correct position is almost vertical, slightly following, so that when you lean on, the elbow naturally glides forward. Number 2, from this view, the shoulder should not be too far to one side or the other, but should be right over the elbow. Appropriate positioning allows an efficient transfer of force into the tissues. 3. Next, make sure to depress the shoulder while doing forearm strokes in order to protect the glenohumeral joint. By depressing the shoulder, the humerus pushes into the acromion, transferring force through the bone and tightening the latissimus dorsi, which pulls the head of the humerus down. This protects the rotator cuff tendons. Don't do it like this. Do this. 4. Next, make sure the wrist is in neutral and the fingers are relaxed. 5. The head should be in relative neutral, perhaps looking down a little, but not in full flexion with the chin touching the chest. The practitioner should not get too close to their work. 6. The lower back should not be rounded, but should be supported. This is achieved by sticking your butt out, which in effect anteriorly rotates the pelvis and causes the correct curve in the lumbar spine. 7. While applying deep tissue massage strokes, especially the forearm stroke, it's important that you are stabilized well. We will stabilize our position in 4 different places. One side of your hip rests against the table, One hand rests on the table, one elbow connected to the tissues of the body, and the fingers connected to the other forearm. In this way, you can regulate your pressure appropriately and apply deep pressure safely. If you need to lighten up, you can place more pressure on the hand that is resting on the table. 8. Apply pressure within 3 inches of the elbow in order to gain a good mechanical advantage. This allows you to apply pressure through the bones without much muscular effort. When you want the pressure to be especially deep and intense, you can use your elbow point. 9. The skin on your forearm is loose. In order to get an effective depth with your stroke, you need to first tighten the skin on your forearm before you can apply deep pressure. To work on the back, start on the sacrum with very light pressure in order to tighten the skin. And when you get to the lumbar area, you will be ready to apply pressure. Stripping strokes with a loose fist. The fist and the knuckles are an excellent tool to apply deep pressure. When applying pressure with a fist, keep the fingers relaxed so that your nails won't bite into your palm. Relax your hand, straighten your wrist, and allow your body weight to push your fists forward. Most strokes done with the fists are done pushing away from the body. Stroke speed, mechanical component. The intention of stripping strokes is to elongate tight muscles and fascia. By performing these strokes slowly, we are able to penetrate deeply and affect lasting change in the body. Faster strokes are more superficial, while slow strokes can penetrate to the core of the muscles. There also is a direct relationship between pain and speed. The slower the stroke, the less pain that will be felt. When clients complain of a painful area, sometimes rather than lightening up, simply slowing down or stopping is enough to ease the discomfort, but will still allow the deep release to continue. Emotional component. Slow and rhythmic strokes demand an attitude of patience on the part of the practitioner. When a practitioner feels there is not enough time for the massage, or when they have resistance to connecting to their client, usually their strokes will speed up. Slow work brings you into the moment, demands that you feel and connect to the receiver. Slow strokes are done from the heart, where fast strokes are usually done from the head. Evaluation techniques. When people come to me with injuries, my first intention is to assess what structures are involved. Generally, most injuries either involve muscles, tendons, or the joint capsule and ligaments. Knowing how to tell the difference between these structures is important. Resistance testing. In order to evaluate the muscles and the tendon unit, we will use a resistance test. Have your client push in a specific direction with 100% of their strength against your resistance. If the muscle or tendon is compromised, the test will elicit pain. By changing the direction of resistance, the therapist can quickly pinpoint the exact site of the injury. Don't let your client push for more than 1 second for fear of straining the muscle too much. When the injury is minor, sometimes the resistance tests won't elicit any pain, and in that case we can use range of motion tests. Range of motion tests assess the integrity of the joint capsule and the ability of the muscles to lengthen. Range of motion tests can also help to reveal postural distortions. To perform a range of motion test, take the client's joint to the end range of its movement. If the joint has good motion and no pain, all is well. Minor restriction that has a springy end feel usually indicates a muscular cause. The springy feel is the muscles restricting the movement before the joint capsule and the ligaments engage. You can address this by releasing the muscles and then rechecking. An empty feeling through the range with a hard ending indicates the joint capsule is stopping the motion. If there is pain at the end range, then the joint capsule and the surrounding ligaments are probably inflamed. To address this condition, your focus should be to cool down the inflammation by static pressure, ice, and other techniques that are good for cooling down inflammation. If there is major restriction but no pain, and this restriction has been chronic, you can bet the joint capsule has undergone fibrotic changes, meaning that it has toughened up in response to some injury. To work with this condition, slow, deep stretches are indicated to loosen the capsule and introduce more motion. By assessing where the joints are restricted, then releasing those restrictions, we can increase mobility and help the person out of pain. The spinal column is a great example of this. I've seen many people with postural distortions in their spine but with no pain. This is because they have good mobility. By increasing mobility, we can decrease pain. In this video, we will use these two assessment techniques, range of motion and resistance, to decide where to work. The most effective way to perform massage is to test, find a motion or resistance that hurts, then work on that area that you feel causes that pain for about 10 minutes, and then retest and see if the pain is easing up. If you're working on the correct area with the correct technique, the pain will usually be diminished by 50% or more. If there is no change in the pain, you need to try a different technique or a different location. This is the most important tip that I can give you in this whole video. Test, work, and retest. Do not test for pain, work a whole session, and then ask your client afterwards if they feel better. This is a common way to massage and is very inadequate when dealing with injuries. When you test, work, and then retest, you can quickly validate if your intuition, anatomical skill, and technique have been accurate. If the pain is not lessened, then you get to try again. When I work, I shoot for an 80 to 100% abatement of the pain and can usually get that in under 20 minutes. Done correctly, massage is very powerful, and these types of results are easy to get. Now that we've covered the basics of pressure, body mechanics, types of strokes, and assessment techniques, let's get to work.
Hip assessment, internal and external rotation. How someone holds their hips has a great influence on the kinds of pain that they'll experience. It's important to evaluate the tension pattern in the hips in order to create more mobility. There are 3 ways to assess for the internal and external rotation of the hips. 1. Notice how your client walks when they enter the session. People whose feet point out and walk like a duck will have tight external rotators. People whose feet point in and walk like a pigeon will have tight internal rotators. If they don't walk like a bird, they're probably okay. The internal rotators are located here, and the external rotators are located here. Next, notice how your client lies on the table. Do their feet splay out, indicating tighter external rotators, or do the toes point in, indicating tighter internal rotators? If one foot lays out and the other in, this can indicate a twisting in the pelvis, which may migrate up the spine. This is a more complicated postural distortion than symmetrical distortions where both sides are the same. Let's look at how this works. In our example, the right leg is externally rotated and the left is internally rotated. When people walk, they usually try to get their feet going straight, like this. But now, notice the position of the upper body. The next compensation is to get the upper body facing forward. Now the feet and head point in the same direction, but the hips are twisted. If you were to draw a line along the ASIS, it would look like this. See how the right side is forward? You can do this yourself by having your client align their feet to a piece of tape on the floor, then place your thumbs on the ASIS and draw an imaginary line between your thumbs. Does this line match the line on the floor? Is one side projected forward and the other side back? Notice how this can tighten the lumbar spine on the right. To unwind this pattern, release the external rotators and lumbar area on the right and the internal rotators on the left. Note that, because of the complexity of the postural distortions, use this information as a guide, but always follow the unique tension pattern in each client's body. 3. The final way to assess the position of the hips is to use a range of motion test. A range of motion test is the definitive way to assess the mobility of the hips. Major restriction indicates a long-term pattern that can involve the joint capsule, while minor restrictions are usually only muscular. Before we perform the range of motion tests, let's get acquainted with the muscles. External rotators. The muscles of external rotation are the obturator internus and externus, gemellus inferior and superior, quadratus femoris, the piriformis muscle, and to some degree the gluteus maximus not shown. Trigger points in the piriformis and other short lateral rotators can refer here. To assess the external rotators, test the range of motion by grasping the ankle, bending the knee to 90 degrees, stabilizing the pelvis with one hand on the sacrum, and pulling the client's leg out towards yourself. Normal motion allows the leg to come out about 30 degrees. If there is restriction, work on the external rotators. Be cautious with the assessment if your client has weak knee ligaments or experiences pain during the test. External rotator technique. Client prone. To work on the external rotators, before applying oil, skin roll the gluteal fascia by picking up the tissue and slowly rolling it between your fingers. Sometimes it's hard to get a good grip, and if that's the case, then just grab a larger area and hold. This will loosen the tissue, increase the blood supply, and make it so that you can feel the muscles underneath with greater precision. To release the muscles in a general way, use your elbow point and strip from the iliac crest inferiorly between the sacrum and the greater trochanter. If you want to make this more intense, hold the leg in internal rotation with the knee bent to 90 degrees. The external rotators converge at the greater trochanter, so we can affect all these muscles by frictioning around the greater trochanter with our thumbs. To do this, place your thumbs just medial to the greater trochanter and friction superior to inferior like this. This affects the piriformis and the go-go's. To work on the quadratus femoris, move down below the head of the greater trochanter and friction with your thumbs. Then use the point of your elbow to apply static pressure. Ask your client about any possible referral patterns and wait for the tenderness to ease up. The piriformis muscle moves medially from the greater trochanter and slightly superior. It attaches under the sacrum about midway. Use your thumbs to trigger point the piriformis attachment at the sacrum. In clients with an inflamed piriformis muscle or sciatic pain, this area can be tender. Sometimes deep pressure can send the muscle into spasm, and if this happens, put the muscle on slack by externally rotating the leg. Then have your client push their leg out towards you, about 50% of their strength, to engage the internal rotators. This will inhibit the piriformis muscle and cause it to calm down. After releasing the external rotators, turn your client to a supine position and stretch by bringing their knee up and across their body. Always ask them where they feel the stretch and move the leg around to get the stretch in the appropriate place. Stabilize the torso with your other hand. Piriformis muscle syndrome. In 85% of people, the sciatic nerve exits the greater sciatic foramen just anterior to the piriformis muscle. Spasm in the piriformis muscle can cause compression on the sciatic nerve, sending pain, tingling, and numbness down the posterior leg. The sciatic nerve can also be compressed at sacral nerve roots and the lumbar nerve roots of L4 and L5 arising from a bulging disc. You can tell if the piriformis is involved if there is piriformis tenderness and limited internal rotation. Lack of mobility in the lumbar spine usually indicates that the cause is in the lumbar spine. Internal rotators and abductors. The muscles that internally rotate and abduct the leg are the gluteus minimus and the gluteus medius. Trigger points here refer pain into the sacrum, and trigger points here refer pain into the SI joint. The tensor fascia lata also internally rotates the femur, and trigger points in this muscle can refer pain here. The adductors can also internally rotate the leg and should be checked for length and tension as shown in the adductor section. To test the internal rotators, push the leg away from you. The legs should approximate each other, and if they do not, then work on the internal rotators. Sometimes I've noticed that people with sciatic pain that relates to piriformis muscle will have tight internal rotators. This is an example of why performing range of motion tests are so important. If I didn't test the hip movement, I'd just end up working on the piriformis and completely miss the internal rotator component. The internal rotators in that case would be stretching the piriformis taut across the sciatic nerve, and loosening up those internal rotators allow the piriformis to regain a normal position. Internal rotator technique. Client prone. To work the gluteus medius and minimus, use your elbow to strip anteriorly between the crest of the ilium and the greater trochanter. The trigger points in the gluteus medius refer into the sacrum and SI joint and can be found roughly an inch below the crest of the ilium in a half-moon shape. Apply static pressure on these spots. Communicate with your client about possible referral pain and wait for the pain to diminish. Then move to another spot. To release the gluteus medius and minimus and to increase range of motion, use your thumb to apply pressure just superior to the greater trochanter where the gluteus medius tendons attach, and then internally and externally rotate the leg. Keep the knee bent at 90 degrees, and don't do this if someone has knee pain. Client supine. Use your thumbs to strip the tensor fascia lata from its insertion to its origin on the ilium. Then apply static pressure near its attachment. Apply static pressure while the client internally and externally rotates their leg. Stretch these muscles by moving the client into a side-lying position, their hips near the edge of the table. With one hand, push the ilium towards their head in order to focus the stretch on the hip and drop the leg off the table. Apply pressure to the leg to get a gentle stretch, working the body forward or back to find the appropriate positioning for the best stretch. The adductors can also internally rotate the leg, so include in this sequence adductor work, shown next.
Adductors. The adductors are important because they are the opposing muscle group to the abductors located on the outside of the hip. There are two reasons to work on the adductors. 1. A groin pull or obvious inflammation in the area of the adductors. 2. Clients with SI joint pain often have tight adductors that are a contributing factor to the problem. The muscles of adduction are the adductor magnus, with trigger points here that refer to this area, the adductor brevis and longus, referring here, the pectineus, which refers here, and the gracilis muscle. To test the adductor magnus, abduct your client's leg away from their body. Keep the foot pointing towards the ceiling. Make sure your draping is as low as the knee so that they feel well draped. The leg should go out at least to a 45-degree angle. Less movement indicates restriction, and massage can be helpful. To test the other adductor muscles, flex the hip and let the knee fall out. Any limitation here indicates the massage also will be useful for the adductors, on the adductor longus specifically. Adductor technique. We will work on the right leg. Brandon is our model. Stand on the opposite side of the table and use your forearm to glide up the adductors. Then, move to the same side of the table, place your thigh under the knee and externally rotate the leg. Then, use your forearm to glide up the adductors from this side. Then, use your thumbs to strip the adductors like this. Next, find the tendon of the adductor longus by having your client adduct their leg against your resistance. The tendon that pops out is the adductor longus tendon. The gracilis tendon is sometimes blended with this tendon, and other times it's more posterior. Okay, using your thumb, apply pressure just anterior or lateral to these tendons. This is the body of the adductor longus. Hold until a softening occurs. Then apply static thumb pressure on the pectineus here. Caution, if you feel a strong pulse, you are probably too close to the femoral artery and need to move medially. Next, squeeze on both sides of the adductor longus and gracilis tendons and move down towards the knee. Stop when it becomes difficult to grasp. For groin pulls, we'll also work the adductor attachments. Have your male clients hold their genitals out of the way and friction the pectineus attachment right next to the pubic bone, just superior to the adductor longus tendon. Then find the adductor longus tendon again and friction just posterior to it from ceiling to floor on the medial portion of the brevis and magnus. Stretch the adductors in the same way that we evaluated them for restriction. The muscles we just worked on play an important role in the positioning of the hips. Let's explore this further. It is common for clients in pain to have one hip higher or lower than the other. This can be caused by an anatomically long or short leg or an anterior-posterior rotation in the pelvis that is not the same on both sides, or a movement up and down in the hip itself. To evaluate the hips, find the top of the ilium with your finger pads. Remember that the ilium is rounded, and that if one hand is more anterior than the other, your measurement will be off. Also remember that we are looking for obvious difference, not subtle changes. If you can't tell which is higher, the hips are probably balanced.
Here is a diagram of what happens when the hips are out of balance. In this case, the right hip is higher, and this creates tension on this side of the back, in the abductors here, and in the adductors on this side. To balance the hips, work all these muscle groups. Sometimes there is pain here. This is because the muscles and ligaments are stretched on this side. Use static pressure to relieve this inflammation, and then work on the other areas to align the hips. Anterior and posterior rotation. The hips can rotate forward and back. To measure the amount of rotation in the hips, compare the bottom of the ASIS with the bottom of the PSIS. Make your fingers horizontal and notice which is higher. If you have trouble finding the ASIS, find both of them together and have your client bend their leg forward. This softens the sartorius and allows you to contact the bone easier. If you're having trouble finding the PSIS, first find both of them together. The PSIS are further out on women and closer in on men. Ideally, in men, the ASIS and the PSIS should be even, and in women, the ASIS should be about a ½ inch inferior. Check both sides. If the ASIS is more inferior than it should be, this indicates an anteriorly rotated pelvis, which increases the curve of the lumbar spine. With this posture, tension is located in the back erectors and also on the anterior side in the psoas and the rectus femoris. However, they usually won't feel tension in the front because the hips are made to move into flexion. But the restriction here will show up with the psoas stretch. Strengthen the rectus abdominis and hamstrings to help balance this posture. If the hips are posteriorly rotated, like this, then the lumbar spine will be flat or kyphotic. To balance this posture, release the rectus abdominis and the hamstrings and gluteus maximus. Hip flexors, the psoas and the rectus femoris. To test for a restricted psoas muscle, have your client bring both knees to their chest, then bring one leg down. If the leg doesn't come down to the level of the table, then the psoas is restricted. If the knee is extended, it can indicate a tight rectus femoris. The psoas muscle can refer pain into the anterior thigh and also into the lower back. The rectus femoris is covered in the extremities video. Work on these muscles if the client has an anteriorly rotated pelvis or low back pain. The easiest place to start on the psoas is just superior to the inguinal ligament. Don't push on the ligament, but find the psoas just superior to it. Circle in through the tissue until you can feel the psoas. Sometimes it can be hard to feel the psoas, so ask your client to lift their leg off the table and then put it down. This will tighten the psoas, causing it to bulge. You should be able to feel it underneath your fingertips. To increase the intensity, have your client flex and extend their hip 3 times, like this. Next, move superior and medial and circle through the intestines again until you reach the psoas a little higher up. Keep working and moving up along the path of the psoas. Higher up, it will be difficult to feel the psoas, but sometimes the main area of tension is higher up near its origin. Find the inguinal ligament and move inferior. Then find the femoral pulse and move just lateral enough so you're not pushing on the artery. This is where the psoas dives deep to meet the lesser trochanter. Apply static pressure with your thumbs or fingers in this area until it softens. Remember, again, lateral to the femoral pulse, it's going to be medial to the sartorius and inferior to the inguinal ligament. These are your landmarks. Next, stretch the psoas by having the client move their hips to the edge of the table. Drop their leg off the table and stabilize the ASIS with your hand, and then stretch the leg towards the floor.
If clients have lower back pain or an anteriorly rotated pelvis, then shift the pelvis posteriorly by holding their opposite leg to their chest. This will help to relieve any pain that was being caused by the compression in the lumbar spine due to the stretch. Hip extensors. Muscles of hip extension include the gluteus maximus and the hamstring muscles, divided into biceps femoris, semimembranosus, and semitendinosus. Trigger points in the semitendinosus and membranosus refer pain into the posterior hip. Trigger points in the gluteus maximus here refer pain into the SI joint, and trigger points here refer pain into the posterior hip. The gluteus maximus was addressed in the hip external rotator section, and the biceps femoris is covered in the extremities video. We'll look at the two semi-muscles here. First, use your forearm to glide up the medial hamstrings. And use your elbow point to apply static pressure between the hamstrings. Then use your thumbs to search for sensitive tissue and apply static pressure on trigger points that may refer into the posterior hip. Finally, stretch. Back. The back is one of the most complicated areas of the body. The connection between the lumbar spine and the sacrum and the ilium means that the back is intimately connected to the hips. The positioning of the hips will directly affect the curve of the lumbar spine and determine what stresses are placed on the sacroiliac joint. Always include hip work when addressing the back. Spring test. One of the major contributions to back pain is lack of mobility. In order to test for spine mobility, we will perform the spring test. Place the hypothenar eminence over the spinous processes and give a little spring towards the floor. It doesn't have to be a lot of pressure, just enough to get a sense of movement between each vertebra. The spinous process in the thoracic area slant in an inferior position, so you need to push slightly superior in this area. Areas of restriction will feel tight and will move as a column instead of individually. When you feel an area of restriction, that's the area that you want to work. Muscles of the lower back. There are 6 important muscles to focus on when working with people with back pain. The multifidi, trigger points in this muscle can refer here. The quadratus lumborum, trigger points here refer pain into the SI joint, and trigger points here refer pain into the crest of the ilium. The erector spinae group, including the spinalis, the longissimus, and the iliocostalis. Trigger points here refer pain into the SI joint, and trigger points here refer pain into the crest of the ilium. The gluteus medius, trigger points here also refer pain into the SI joint, and trigger points here refer pain into the sacrum. And finally the psoas. Trigger points in the psoas here can refer pain into the anterior leg, and trigger points here can refer pain into the back. So when someone enters with SI joint pain, first think about the stress on the SI joint due to postural distortion, and then these areas which all refer to the SI joint. Other important muscles related to lower back pain are the piriformis, with trigger points here referring this area, and the serratus posterior inferior, referring pain around itself, and finally the gluteus maximus and the rectus abdominis, both not shown. Back technique. Sunny will be our model for the back section. First, release the longissimus by using your forearm to glide up the back, just lateral to the spine. Next, release the multifidi by starting at the edge of the longissimus and use your thumbs to push towards the spine at a 45-degree angle and glide superiorly. This muscle is often tender in people who have lower back pain. To work the iliocostalis, friction its attachments to the inferior part of the ribs, here. Start on the 10th rib and work each rib until you reach the inferior angle of the scapula. To release the spinalis, stand at the head of the table and use your fingers to friction superior to inferior right next to the spinous processes all the way down. This muscle oftentimes will be very tight in the area of pain, and in these areas use static pressure. Next, release the quadratus lumborum by using your elbow point to glide anteriorly between the 12th rib and the crest of the ilium. Then use your thumbs to glide up the QL. When you reach the 12th rib, friction medial to lateral at its attachment there. Then friction the attachment to the ilium. To release the trigger points in the QL, apply pressure at a 45-degree angle just inferior to the 12th rib and just lateral to the transverse process of L1.
This is the major trigger point area of the QL that refers pain into the SI joint. Trigger points in the serratus posterior inferior can also refer into the lower back. Find the lowest rib, move up about an inch, and apply pressure into the muscle belly. Ask your client if they have any referral pain. To help clients with restricted breathing patterns, release the intercostal muscles by stripping in the space between the ribs using your 2 index fingers. To stay in the correct groove, it can be helpful to move your fingers back and forth a little. The iliolumbar ligament connects the L5 transverse process to the ilium. Find it by moving medially over the crest of the ilium until you feel the edge of the erector muscles, then friction just next to the ilium through these muscles, penetrating to the ligament. Stretch the QL and gluteus medius by dropping the leg off the edge of the table while stabilizing the rib cage with your other hand.
The anterior torso. In this section, we will work on the internal and external obliques and the rectus abdominis with trigger points here that refer to the back. To release the rectus abdominis, friction across the lower ribs, right where the rectus abdominis attaches. You should feel the fibrous tendons as you move across, directly on top of the ribs. Next, brace one area with your thumb and use your fingers of the other hand to pull down towards the pubic bone. This will stretch and release the body of the rectus abdominis muscle. The main focus is the pull, not deep pressure into the belly. Keep bracing with your thumbs as you move down the muscle. Finally, find the pubic bone and use your fingers to friction the superior portion of the pubic bone where the rectus abdominis attaches. Be aware to stay off the inguinal ligament, just lateral to the pubic bone. To release the oblique muscles, kneel at the side and alternately squeeze the muscles between your fingers and thumb. Then apply static pressure and hold. Wait for a release to occur, and then move to another area and do the same thing. Alternate these techniques until the muscle is nice and pliable. Before we move on to the shoulder, I'd like to show you another way to perform some of the strokes that we've been looking at. Side posture. Have your client lay on their side, facing away from you, and drape them appropriately. Adductors. Use your forearm to glide up the adductors. Then use your thumbs to search for sensitive tissue. Next, friction the upper part of the adductor attachments. This is a great position to friction right on top of the gracilis or adductor longus tendons. Then gently friction down the leg, looking for areas of restriction. To release the abductors, redrape and glide from the ilium to the greater trochanter with your elbow. Then use your thumbs to friction the gluteal attachments to the ilium. To work the external rotators, apply thumb pressure to the piriformis muscle. Then use your elbow point to glide inferior. To release the quadratus lumborum, your client's top leg is straight and their top arm is over their head. This will separate the ilium and the 12th rib. Use your thumbs to glide up on the edge of the QL, then friction the 12th rib attachment. Then apply static pressure on the muscle. Face the feet, glide down the muscle, and then friction the ilium attachment. And then finally apply static pressure from this angle. The scapula movers. The shoulder is really separated into two different muscle systems, the glenohumeral joint, covered in the extremities video, and the scapula's movement on the torso, covered here. Scapular retractors and elevators. Evaluate your client's posture. Notice if the shoulders are forward in relationship to the hips. People with upper back pain will often have this posture. Don't perform stripping strokes or stretches on these muscles that are already too lengthened and tired out from holding the shoulders from slumping even more. Use static pressure to relieve the inflammation, then work on the scapular protractors on the front to help the shoulders move back. The main muscles of scapular retraction are the rhomboids, with trigger points that refer here, and the middle trapezius, with trigger points that refer here. The upper fibers of the trapezius elevate the scapula, and these trigger points refer here, and these trigger points can cause headaches. The levator scapula also elevates the scapula, and its trigger point refers pain here. A tight levator scapula will also restrict neck rotation, so include it with all your neck work. To release the muscles of the upper back, stand at the head of the table and use your elbow point to glide towards the head. For people with concrete back syndrome, apply static pressure with your elbow point and hold until a softening occurs. Then, use your thumbs to knead the rhomboids and trapezius and apply static pressure to trigger point areas. Next, bring your client's arm out to the side, move to the side yourself and squeeze the upper portions of the trapezius between your fingers and thumb. Then move to the head of the table and apply static pressure on the distal end of the trapezius, just next to the clavicle and the scapular spine where they meet. To release the levator scapula, get a handful of trapezius, let go of the upper half and squeeze the levator scapula underneath. Then apply static pressure just above the superior angle of the scapula where the levator scapula attaches. Stretch the levator scapula by flexing and rotating the neck. Rotate the neck in the opposite direction for the upper trapezius. Scapula protractors. Work these muscles if a client has forward shoulders, a slumping position, or needs to open their heart. The main muscles of scapula protraction are the pectoralis major, with trigger points referring here, and the serratus anterior, with trigger points that refer here. To release the pectoralis major, use your fingers and palm to glide out from the sternum towards the humerus. Then use your fingertips to friction just inferior to the clavicle. And then friction between each rib next to the sternum. On women, reach the inferior part of the sternum through the draping. Next, squeeze the edge of the pectoralis muscle between your fingers and thumbs, looking for fibrous tissue and trigger points. Stretch by bringing the arm into abduction and external rotation. This position gets the lower fibers of the pec major, here the middle fibers, and here the upper fibers. To release the serratus anterior muscle, position your client face down, stand at the opposite side of the table, and use your fingertips to glide towards the scapula, applying pressure to the rib cage. The neck. We will divide the neck into extensors and rotators, lateral flexors, and flexors and anterior neck. Neck extensors and rotators. The deepest neck extensor and rotators are the suboccipital muscles. Trigger points refer pain here. Next, the semispinalis cervicis, then the semispinalis capitis with trigger points that refer here. Over these muscles is the splenius capitis with trigger points that refer here. Wrapping around this muscle is also the splenius cervicis, and over the top is the trapezius with trigger points that refer here and trigger points that also refer here. On the anterior side, the sternocleidomastoid muscle can refer pain here. Here's a compilation of trigger points that can cause headaches. First, evaluate neck rotation by rolling your client's head to each side. The chin should approximate the shoulder. Restriction indicates tight rotators, usually on the same side that you're rotating to, but to be sure, ask your client where they feel the restriction or pain. To evaluate for flexion, bring the chin to the chest. It should get to within a ½ inch of the sternum. To release these muscles and increase range of motion, use your thumb to strip the posterior neck muscles. Then, friction the transverse processes. Next, use your thumb to trigger point the splenius capitis at its attachment to the occiput. Then passively move the head to allow the thumb to penetrate to the deeper muscle layers. Apply static pressure and move your thumb down the posterior neck while moving the head. This is a great way to increase range of motion. To release the sternocleidomastoid muscle, have your client gently rotate and flex their head against your resistance to make the muscle pop out. Pinch the muscle between your fingers and thumb and work up. Then friction the attachment of the mastoid process. Then, just superior to the clavicle on the clavicular head. Cross your hands and stretch these muscles by rotating the head to the side. Then stretch into flexion and rotation for the levator scapula, and flexion and opposite rotation for the upper trapezius, and straight flexion finally for the posterior neck muscles. Neck lateral flexors. The muscles that laterally flex the neck are the scalene medius, scalene anterior, and scalene posterior. Trigger points in these muscles refer here. The scalenes are of special importance because the brachial plexus emerge between the scalene anterior and the medius. Nerve impingement can cause numbness, tingling, and sensory loss in the 4th and 5th digits, the ulnar side of the hand, and sometimes the forearm. Always check the scalenes for tension when dealing with arm pain. Functionally, the neck is divided into two parts, the upper neck and the lower neck. The upper neck is controlled by the suboccipital muscles. Movement occurs just at the top of the neck. The bones involved are the atlas and the axis. The lower neck is controlled by the scalenes, and here the motion occurs in the lower neck. When you evaluate, notice what area is holding tension. To evaluate the neck, laterally flex the head from side to side, keeping the face up. There should be motion at the top and at the base. You can also just evaluate the suboccipital area, like this. Also, notice how the head rests on the table. Is it tilted to one side or the other? A common postural distortion is a tight scalene group on one side and a tight suboccipital group on the other. In this situation, work each muscle group to rebalance the posture. To release the scalenes, apply static pressure to the scalene anterior, just lateral to the sternocleidomastoid. Work up the muscle. Then apply gentle cross-fiber friction. Next, apply static pressure on the scalene medius. Then gently cross-fiber friction the muscle. Finally, add lateral flexion while you apply static pressure. Stretch the scalene medius by bringing the ear to the shoulder and stretch the scalene anterior by turning the face into the stretch like this. Anterior neck. Victims of whiplash syndrome will often have strained and tight anterior neck muscles. This is also a great routine for singers. The most superficial anterior neck muscles are grouped as the infrahyoid muscles, the muscles below the hyoid bone, and the muscles that are just above the hyoid bone, the suprahyoid muscles, which aren't shown here. These muscles lay right over the trachea. Under the trachea, the longest colli and the longest capitis are directly over the anterior cervical vertebrae. And close by are the carotid artery and the internal jugular vein. Be careful of these structures. A gentle way to test for neck extension is to use your fingertips to push the cervical vertebrae towards the ceiling, checking for mobility. Next, move to the side of the table. To release the infrahyoid muscles, stabilize the side of the trachea with one hand and friction lateral to medial over the trachea with your fingertips. To release the muscles above the hyoid bone, the suprahyoid muscles, gently glide out with your fingertips, and then on one side apply static pressure with your fingertips and move out. Then gently friction just underneath the mandible. To release the longest colli and capitis, turn your client's head towards you just a little. Help them extend their neck a bit and place your forearm on your partner's chest. Have them grasp your arm and then push the trachea aside and use the index finger of the other hand to apply pressure to the anterior spine. If you feel a pulse or soft or mushy tissue, you may be pushing on the artery or nerve, so move to a new location. Release the muscles as far up as the hyoid bone and as low as an inch above the sternum. You don't have to do a lot of work in this area because it hardly ever gets touched, so just a few seconds of gentle rubbing is enough. Be aware that sometimes you can initiate a gag reflex lower down. Release both sides.
This video covers a lot of information. Watch it once and practice it on your clients, and then come back and watch it again. I'm sure you'll find an added depth to it. I really enjoyed making this video. Thank you for watching, and I hope it helps your practice.